Thank you for the opportunity to be here this morning. I'm going to switch gears from the microscopic to more macroscopic topic. And in the next 10 minutes, I'd like to briefly tell you about some studies in neuroimaging that we've been performing on patients with upper motor neuron predominant ALS and my future plans for continued research in this area. A former postdoc, Dr. Venkateswaran Rajagopalan, who went back to India, now performed the analyses on these studies. I have no disclosures relevant to this presentation. So although by definition, ALS occurs when both upper motor neurons and lower motor neurons degenerate in the brain and spinal cord, many patients initially present to the neurologist with abnormalities primarily or exclusively of upper motor neuron or lower motor neuron pathways. However, with disease progression, the opposite pathway usually also degenerates, resulting in combined upper and lower motor neuron dysfunction. Through my neuroimaging research, I became particularly interested in ALS patients who present with predominantly upper motor neuron dysfunction, where disease primarily affects motor tracts descending from the brain into the spinal cord. Now, routine or conventional brain MRI, as regularly used during clinical evaluations of patients with ALS, usually shows no obvious abnormalities. Here are 4 views through the brain of a patient with upper motor neuron predominant ALS that show no abnormalities on FLAIR imaging. We see images in horizontal. Let's see if I can find the horizontal views up at the top, coronal in the left lower, and sagittal in the right lower. Orientations showing levels where you'd see the main descending upper motor neuron pathway that's called the corticospinal tract, or CST for short. And as shown in the diagram adjacent to the horizontal view, the CST is found in a circumscribed area in the posterior limb of the internal capsule. However, some patients with upper motor neuron predominant ALS have visible hyperintensity of the CST on conventional FLAIR and T2 weighted MRI, as shown here, but little is understood what this means. CST hyperintensity is usually most evident at the internal capsule level, as shown on the left, and cerebral peduncle level, shown on the right, but sometimes can be seen tracking along the rostrocaudal extent of the CST from higher subcortical levels, as seen here in a coronal view on the left and sagittal view on the right. We discovered that many upper motor neuron predominant patients who superficially appear identical to those with CST hyperintensity do not show the signal change on conventional MRI. This was initially quite puzzling and raised questions why this is. We therefore prospectively evaluated 45 patients with upper motor neuron predominant ALS who by conventional MRI either showed CST hyperintensity, who I'll refer to as ALS CST plus, or did not show it, who I'll refer to as ALS CST minus. After clinical evaluations and additional specialized MRI analyses, we found interesting differences between the 2 subgroups. Although these ALS patients had the same degree of upper motor neuron involvement and functional deficits as measured by the revised ALS functional rating scale, or ALS-FRSR, patients with CST hyperintensity were almost 8 years younger, had been experiencing their symptoms for a much shorter period of time, less than a third as long as the other subgroup, and had a monthly progression rate of disease that was about 3 times as fast as patients without CST hyperintensity. Although conventional MRI was useful to initially identify the 2 subgroups of upper motor neuron predominant patients, we next used more advanced MRI techniques, including diffusion tensor imaging, or DTI, and diffusion tensor tractography, or DTT, to examine these differences more objectively and at a submacroscopic level. Now, DTI and DTT of brain white matter reveal the integrity of fiber tracts and can display them virtually as well as quantitatively. After selecting top and bottom levels of the brain in the left side that you can see there, between which fiber tracts are known to project, we can visualize the virtual motor tracts, including the CST, shown in green in a healthy individual in the left panel, and in a patient with ALS, where it appears thinner on the right side. The principle of DTI and DTT is based on the movement or diffusion of water molecules throughout tissue. In brain white matter, normal integrity of axons restricts water diffusion to tract mostly along the length of axons, as you can see in the left panel. When axons are disrupted, however, as during degeneration in ALS, on the right, diffusion becomes abnormal with more movement across the axons and less movement along their length. We found that the CST is truncated and appears quite thin in upper motor neuron predominant ALS patients, as seen on the right, and is never truncated in control individuals where it appears thicker, as shown on the left. Importantly, we also found CST truncation much more frequently in ALS CST plus patients than in ALS CST minus patients. Furthermore, this truncation appears to be specific to descending CST motor fibers, shown in red, as compared to ascending sensory fibers, shown in yellow, which appear relatively spared. This suggests that truncation is not a random process affecting all motor fibers, or all fibers, but is specific to motor tracts. We next evaluated whether other brain white matter tracts besides the CST show differences in degeneration between upper motor neuron predominant patients and controls, and particularly between those with and without CST hyperintensity. If so, this would suggest more global differences in brain degeneration between these two subgroups. We used a mathematical technique called graph theory to analyze white matter interconnections or networks between multiple brain regions in patients compared to controls, as well as in patients with and without CST hyperintensity, to look for different patterns of white matter degeneration between the ALS subgroups. What you see here are multiple brain regions marked by an X, where white matter degeneration occurs in all upper motor neuron predominant ALS patients compared to neurologic controls. The majority of marked regions without color are abnormal, but only in ALS patients of one or the other subgroup. Only a few blue-colored cells show brain regions where white matter degeneration occurs in both subgroups, while those marked in red indicate significantly more degeneration in ALS CST plus patients than in ALS CST minus patients, whether or not significantly different from controls. In summary, we have shown by clinical and advanced brain MRI analyses that ALS patients with and without CST hyperintensity appear to be distinct subtypes of ALS with differing regions of brain degeneration. This also suggests these subgroups may have unique mechanisms of disease progression that support stratification for clinical trials, and if better understood, could lead to identifying specific molecular targets for novel therapies. Future studies to characterize additional MRI and hopefully molecular differences between these two patient subgroups I'm planning include MRI of upper motor neuron pathways in the spinal cord and how degeneration there correlates with that in the brain, identifying distinct biomarkers in plasma and serum by proteomic and metabolomic analyses, examining postmortem brain tissue from patients with and without CST hyperintensity for clues to differences in degeneration between in different areas of gray and white matter, and generating motor neurons and neuroglia from induced pluripotent stem cells of these two patient subtypes to evaluate potential differences in RNA and protein expression. So with that whirlwind, I thank you and appreciate it.